So I hope those slides have given you an overview about how transplant is becoming a more accessible, better tolerated treatment regimen for the patients with acute myeloid leukemia, for whom chemotherapy may put you in remission, but it doesn't get rid of the disease. I hope I've identified some of the toxicities that patients may experience in terms of the intensity of treatment in hospital, infections. The major one, I think, is graft versus host disease, which you can get acutely in the first 90 days post-transplant, or it can continue after that. And so in that context, the work of the US BMT Clinical Trials Network, which is similar to ours, and we got our inspiration from the US, have just published in the New England Journal 3 weeks ago a really important study using this drug, post-transplant cyclophosphamide, as a way to reduce GVHD. And that really important transplant trial showed less GVHD, either acute or chronic, in the transplant setting. So I think, my fundamental message is, by working together, by patients being put right at the heart of trial design, by ensuring that we invest in clinical trials so patients access these new treatments, we are incrementally making progress, either using drugs or increasingly using the power of immunotherapy in the form of a transplant. So thank you for your attention. I'm very happy to take any questions. Yeah, so I think, the decision about whether to go to a transplant or not should be made with your leukemia doc, and possibly also the input of a transplant doc. If the outcome just of chemotherapy alone is destined to be that the disease is likely to come back, then there's an appetite, I think, among clinicians and patients to think about transplant. You need a donor. Typically, for an AML transplant, you need to be in remission. But if you're fit, and in our center up to 75, I think in the States it may go up to 80. And of course, it underlines that it's not chronology, it's biology. So you can get some extremely fit 75-year-olds much fitter than a 55-year-old if they've looked after themselves or they've been fortunate with their comorbidities. So it's really in our center to be up to 75. Yeah, I mean, I think, the questioner is right that we are steadily improving transplant outcomes, and we need to be thoughtful always. Are there particular comorbidities that don't matter? So, one of them might be a modest cardiac comorbidity, somebody who had some cardiac stents 10 years ago after a heart attack, and now they're running and up hills. Well, that doesn't matter. But I think increasingly we're beginning to try and hone down on which are the comorbidities that really do matter. So that's one statement, and you should discuss that with your doctor. The second is, this drug, post-transplant cyclophosphamide, it may be that we are able to reduce the risk of GVHD significantly, and that may allow us to take patients with more comorbidities into transplant. The worry one has with GVHD is that you usually can control it, but it needs steroids. And older people, particularly people with comorbidities, don't tolerate steroids very well. So if we are better at controlling GVHD, we may be able to continually increase the kind of threshold or decrease the threshold for taking people to transplant. But, Ralph expressed it, I think, very well. This is a time of continual progress. And we should, as a community of patients and physicians, be thinking about how do we work together using clinical trials, using expert networks, using access to innovation. How do we think about continually improving outcomes year by year and decade by decade?
Thank you, Professor Craddock, for your information. If I can ask you a question from the psychological side. I'm a clinical psychologist working with the psychological side, especially with the chronicity of the illness. So I just want to know, when you do these trials with patients, is there any space or platform for them to give feedback about how they cope with the treatment, the chemotherapy, the side effects, and the chronicity of the illness?
Yeah, I think it's a very good question. So at the moment, it's been such hard work just to set up this transplant network that the studies we've focused on are actually, you know, asking kind of very blunt questions about condition regimen and chemotherapy and stuff. But I think your question's on the money. And, you know, Ralph was talking about, I was particularly struck by what Ralph said. He may want to comment on this. Is well, I mean, certainly as a kind of imperfect clinician, I'm continually aware that we don't think through what strategies we could adopt that would make the tolerability of this intensive treatment schedule better for patients and their carers. And I think there's a big space here for psychologists and you know, clinical nurse specialists,
Yeah.
trying to identify what are good coping strategies. And then I'd like to see a randomized trial. So
Yeah.
the point about a randomized trial is you have to define a primary endpoint. Well, you could work out a primary endpoint. Because the power of a randomized study is if you show that a particular intervention is a benefit, then it becomes globally significant and it becomes practice that should be adopted across the world. The worry is that, you know, individual units do different individual things and we're missing out by not working together. So those have been my observations, but it'd be interesting to know what Ralph thinks.
Okay, thank you very much. Thank you.
I'll give you a little perspective on that. I was 71 and the news was all pretty bad. And so I started thinking, well, let's see, how's that 71 years gone? It's been pretty darn good. So I started thinking this would be a terrible thing for a 16-year-old or a 30-year-old. So I remember after being diagnosed for about a month, and this is uncharacteristic of me, I had no hope. Sure, it was a mystery, but the mystery was part of, I don't know what's happening here. And the thing was, no hope is different than not having any. Well, no hope is one thing, but I didn't want to go. I had a good life. I had so much to live for. I don't know. I never had any counseling. I don't know what to say. I feel sometimes like I missed a lot of it. The hospital where I go for my treatment every month, they have counselors. I think it's an important factor that we have to add in there. I just don't know. I might have missed most of it.
And I suppose, Ralph, you know, there are creative routes, aren't there? One is, you know, an opportunity to have input from somebody who's good as a counselor. Does that make a difference? Is building networks useful? Is access to stuff on the internet helpful? Is aromatherapy? I mean, you know, there's a whole bunch of stuff that you could think about deploying to try and ease some of this burden. And my sense is that we are falling behind in terms of getting input from our psychological colleagues about thinking, how do we alleviate this very significant distress and challenge both the patient and carers? And there are a bunch of questions we could ask that could develop new coping strategies that would be of great importance for people going through this intensive treatment.
Can I say something here? What I find is that when you don't see a psychologist that specialize in oncology, you use up a lot of psychological energy to try to figure out what is going on and what your emotions are, and you also sit with the burden of your family. So there's a lot of wasted energy, psychological energy that goes into that process. While when you speak to somebody during the process, you actually save that energy because now you know what is going on, you know the reaction of your psychological, of your body, and the side effects of your psyche, and you can use the energy to heal, if I can say it like that, more on the biological side, if that makes sense.
And I guess I'd say if we could demonstrate that in a randomized trial, boy, would that change practice worldwide.
Yeah.
Yeah.
Sorry, can I just jump in there? Sorry, it's very, very topical for me because I was diagnosed with AML at 39. You can imagine like massive trauma and everything. And I had an 8-year-old daughter. I still have a daughter. She's now 17. But the impact on her causes a lot of problems as well. So actually, at the moment, there is a trial going on in the UK called Propel, which is got some interventions looking at treatment. And one of the interventions is psychological, with a view to showing that psychological intervention during AML treatment is really important. I had no help at all psychologically. My family didn't either, and the impact of that has been massive. Massive impact on my life and my family's life. So yeah, kind of like just basically back up everything that everyone's been saying so far. You're basically left trying to deal with what is kind of like a massive diagnosis. And kind of not knowing whether you're going to live or die, not knowing if you're going to be here in 2 years' time, 5 years' time. It's definitely something. And also I felt like, and I talk about this a lot in a lot of work that I do in patient advocacy now, that it's almost like, as Vanessa sort of alluded to, use a lot of energy up trying to deal with it, with everything psychologically, whereas if you had sort of like some kind of intervention during this time, you'd be more like a prevention rather than a cure, so that when you're sort of finished treatment, you're then dealing with like a trauma, a PTSD type of situation. So yeah, I just wanted to add that in there, really.
Yeah, no, I think that's a great question. So Propel was developed by the AML group I chair in the UK. And
Yeah.
I think it's the only randomized study of its sort in Europe.
Yeah.
But the inspiration that Simon Stanworth and Justin Loke, who led the study with real vision, was actually what happens in other cancers where the idea of prehabilitation is widely used.
Yeah.
So I think, the point is we could wise up and learn from other settings. It's very well made by you. I agree completely. The outcomes are steadily improving. The toxicity is less. We had a 73-year-old lady who did a transplant from Sandwell, West Bromwich, West Midlands. If anybody knows it, it is not the most affluent part of the world. And she went home on day 13. So she's been in hospital for less than 3 weeks, and she's doing great. She's up in Scotland at the moment. So I think we are really making progress, particularly extending it to older adults. We're getting better at finding donors, but I think still there are major areas where we talked about psychological issues, but there's still toxicities that we see. But the real challenge is when the disease comes back, and we need some game changers there, and we're only going to do that through trials. But if I look in my waiting room, I did a busy clinic this morning. I can see, I suppose, about a fifth of the patients, a quarter of the patients who are happy and with their families, who I see now. That wouldn't have been the case a decade ago. So that is some reason for celebration.
Just quickly as well, because I've been aware of some very early stage discussions about the gut bacteria and treat that during AML treatments. I wonder what your thoughts were on that, Charlie.
Yeah, no, I think really exciting.
Yeah.
Some very encouraging data. We need randomized trials. Anna, we need to be, as a community, saying we've invested trillions of pounds and dollars and francs and euros into basic biomedical research in amazing institutions. We've now got all these new treatments. It's time to change the model. So it's really important that we have a patient-centered approach towards science in treating blood cancer now. And the best way that we're going to move patient outcomes forward is doing the sort of trials that we've spoken to. Mm-hmm. We spend a bit less money now, Anna, in the UK on blood cancer trials than we did 10 years ago. And I think that is completely inexplicable.
Right. Yeah.
And your voice is very important in making
Yeah, I mean,
change.
I am quite loud in the blood cancer community generally, and I actually work with Simon on that Propel trial. So,
Yeah, and in that context, I would take my hat off to Cure Leukemia, who've just invested
yes.
£3 million in trials, to
Yeah.
Anthony Nolan, who've invested £1 million, to Luca UK, who are investing, and to NHSBT. And I think the rallying cry for all blood cancer charities is focus on getting patients to see these new treatments and looking after them so that their holistic care is better.
Yeah.
It's a real call to arms.
Yeah, absolutely. Absolutely.